You're listening to This Week in Cardiology from theheart.org on Medscape.
Hi everyone, this is John Mandrola from theheart.org Medscape Cardiology, and this is This Week in Cardiology for August 31st, 2018, and this will be an ESC wrap-up show. So during the podcast, I'll alternate between interventional and non-interventional trials, and there were too many studies to cover in one show, so next week I'll also have some ESC studies to cover as well. And first of all, I want to say how thankful and honored I am that many of you came up to me at ESC and said you listened to the podcast. Wow, this means a lot to me. I'm much more comfortable writing than I am speaking, so to know that people listen really boosts my confidence. Now, another thing these interactions impress on me is how cool it is that this new digital world connects people across the globe. I mean, we may be separated by oceans and thousands of miles, but social media brings us together as colleagues. Okay, so I just got home from Munich and the ESC, and I want to make a brief comment on the meeting itself. Now, there were more than 30,000 attendees, and ESC is now crushing American meetings, which have been plagued by decreasing attendance. Now, over a beautiful Bavarian dinner, a friend and colleague from Europe told me that the new regulations governing conflict of interest have made it harder for European docs to travel to the meetings. But if so, I couldn't really notice it at ESC. The place was jammed, and it was much more so than I remembered the last time ESC was in Munich. Also, the ESC organizers do a fine job putting this meeting together. And if any of them are listening, I want to say thanks for inviting me as faculty. It was a real honor to speak at ESC. And I won't brag too much, but I think this time I actually won my left atrial appendage debate. Now on to the studies, and again, I'll carry some over to next week. The first is aspirin. Two big mega trials presented at ESC inform the question that comes up all the time. Should people with cardiac risk factors but without cardiac disease take aspirin for prevention of events? So the ARRIVE and ASCEND trials filled an important knowledge gap. While tons of studies have been done for aspirin use for secondary prevention, and these show benefit to aspirin, and some studies have looked at aspirin for primary prevention, the studies of primary prevention have included people at pretty low risk of heart disease. So the authors of ARRIVE and ASCEND aim to inform the growing millions of people with moderate risk due to the accumulation of cardiometabolic risk factors like diabetes, hypertension, and high cholesterol. I'll start with ASCEND. ASCEND included only patients with diabetes, and in that trial, aspirin did reduce major adverse cardiac events, MACE, by about 1% in absolute terms, but it increased GI bleeding by a similar amount, 0.9%. So the authors of ASCEND added a net benefit conclusion, and namely that in this population, they said the benefits of aspirin are countered by the bleeding harms. And in ARRIVE, which included moderate risk patients, in the intention to treat primary analysis, aspirin did not significantly reduce major adverse cardiac events, but did increase GI bleeding. Now, ARRIVE had two big challenges. The first was that there were lots of crossovers. Many subjects in the control arm began taking aspirin, and many subjects in the active arm stopped taking aspirin. Now, the other problem with ARRIVE was that the observed rate of MACE, major adverse cardiac events, was way lower than what was expected by the subject's predicted risk. So, in the ARRIVE trial, in the as-treated analysis, which includes only patients who took the aspirin, the drug did reduce the rate of MI, and this preserves and confirms the biologic effects of aspirin. Now, of note, in both of these studies, it's important to know that non-fatal events drove the efficacy and safety outcomes. Aspirin had no effect on mortality or fatal bleeding. So the two take-homes is one is that secular trends and increased uptake of preventive therapies have decreased cardiac events rates, which is good news for patients, but also news as it gives further evidence that current risk calculators are probably overestimating risk. So I fall close to Professor Armitage, the PI of ASCEND, who counseled that patients like those in her study, diabetic patients, would be better off spending their energies working on risk factors rather than taking an aspirin per day. Second topic is cardiogenic shock. So patients with cardiogenic shock due to acute MI do better with early intervention. Most of these patients have multivessel disease. The question facing the intervening cardiologist is whether to do just the culprit lesion or fix the multiple lesions. European guidelines and North American appropriate use criteria favor doing both the culprit and non-culprit vessels. And last year, the culprit shock RCT challenged the guidelines when it found that patients in the culprit-only arm had lower death rates and renal failure rates, which was the primary endpoint, than those in the multivessel arms. Now, that was a 30-day follow-up. At this year's ESC, the culprit shock authors presented one-year results, and much of the findings were upheld. Death occurred in about 50% of the culprit-only group versus 57% of the multivessel group, and the point estimate for that was a hazard ratio reduction 0.88, though the confidence interval did reach 1.01 on the upper arm. Recurrent MI was also no different in the group, and a composite of death, recurrent MI, and hospital admission for heart failure was also no different. Now, one secondary endpoint, the secondary endpoint of repeat revascularizations, was higher in the culprit-only group, but of course, this was because that was the strategy. Now, this less is more finding challenges the guidelines, and in doing so, it does three things in my mind. One, it helps sort out the best way to treat a serious and common presentation of heart disease. Secondly, I hope that it injects a bit of humility to the guideline writers that had an untested strategy listed as highly appropriate. And finally, this finely done trial teaches us the power of the RCT over observational data for sorting out the best medical therapies. Next topic is VTE prevention, venous thromboembolism prevention. Now, we've got pretty good at making sure people who get admitted to the hospital with acute medical conditions receive VTE prevention. Now, whether this should be continued after discharge is not known. The makers of rivaroxaban thought maybe their drug could help prevent VTEs after discharge. So they funded the Mariner trial, an RCT that randomized medically ill patients who were at risk for VTE to either once daily rivaroxaban at a dose of 10 milligrams or placebo for 45 days after hospital discharge. And the primary endpoint was a composite of symptomatic VTE or death due to VTE, and it occurred in 1.1% of the rivaroxaban group and 0.8% of the placebo group, and the 0.3% difference did not reach statistical significance. Okay, so you say, great, we can not prescribe this drug for this indication. But here's the problem. In the press conference, the PI of the industry-sponsored study said this, quote, "What this means from a population and other point of view is that we now have the ability to optimize thromboprophylaxis in appropriately selected medically ill patients, and we may reduce by half or more the incidence of symptomatic venous thrombosis at the cost of little to no serious bleeding." Then he said this, "When we look at modeling estimations of 6 million at-risk patients that would likely qualify for Mariner inclusionary criteria, we could prevent annually up to 10,000 fatal or non-fatal pulmonary embolic events in these patient populations annually at the cost of 1/10 that number of life-threatening or fatal bleeds." And I say no, no, double no. This is the kind of hype that crushes trust in industry-physician collaboration. Here you have a study of more than 12,000 patients, and the difference in a legitimate endpoint is essentially nil and has a p-value greater than 0.1, and then you have to say the best evidence says we should not prescribe this medication for this indication. The next topic has to do with helping patients with heart failure and secondary mitral regurgitation. When the left ventricle fails, the mitral annulus dilates, pulls downward on the papillary muscles, and this results in secondary mitral regurgitation. In short, the left ventricle is the problem. Nonetheless, many doctors in Europe believe the MitraClip device could lessen the mitral regurgitation and then help people. I found a review article on secondary mitral regurgitation that lists a table of more than 10 registries with in total thousands of patients who have had this device implanted in Europe for secondary mitral regurgitation. Then, crucially, after these thousands of people have had this device, we now have an RCT that was presented and published in the New England Journal of Medicine, presented at ESC, and it's called the Mitra FR, and it enrolled about 300 patients with severe secondary mitral regurgitation in multiple French centers, and it was MitraClip versus medical therapy. And at 1 year, there was absolutely no difference in the primary endpoint, which was all-cause death or unplanned hospitalization for heart failure. Nor was there any difference in the more selective per-protocol analysis. And that's crucial because in this analysis, only patients who had the device were compared. And even when you exclude patients in the device arm who did not get the device, there was still no benefit in the primary endpoint. The rate of complications with the device was 14.6, and there was a 7-fold higher rate of strokes that occurred in the device arm. We have both a news coverage and a feature column that I wrote on this topic. Now, I got in a bit of trouble for my decidedly negative take on this, because another trial looking at MitraClip for secondary MR is due to be released at the TCT meeting in a few weeks. But I strongly believe that valvular heart disease is taking over from PCI as the next big area of overdiagnosis and overtreatment in cardiology. Next topic is the Commander heart failure trial. Now, I don't know why people thought low-dose anticoagulation with rivaroxaban would improve outcomes in patients with heart failure. But Commander HF, an RCT of over 5,000 patients with heart failure with reduced ejection fraction, coronary disease, a high BNP, and no atrial fibrillation, the dose of 2.5 milligrams of BID of rivaroxaban did not reduce a composite endpoint of major adverse cardiac events. Okay, I say, good on the investigators. Now clinicians know not to use this drug for its antithrombin properties in this patient group, and scientists know not to study this question again, and we can move on. Next topic is the treatment of patients with non-ST elevation MI or ACS. Danish investigators performed a verdict trial. This is an RCT comparing very early invasive evaluation of patients with non-ST segment elevation acute coronary syndrome within about 5 hours versus a strategy of less urgent evaluation within 2 to 3 days. Now, the trial shows the very early invasive approach did not improve overall long-term clinical outcomes, a composite of death, non-fatal MI, hospital admission for refractory ischemia, or hospital admission for heart failure. However, similar to previous studies, specifically the TIMAX trial, patients with a high GRACE score greater than 140, which was a pre-specified but secondary subgroup analysis, did better with the early invasive strategy. The hazard ratio was 0.81, with confidence intervals that did exceed 1.0. I noted that about 5% more of the patients in the early group had revascularization, 88% versus 83%. So take a look at our news story on this trial. It's excellent. So the trial discussant at ESC, he took the approach, there is no difference overall, so why should we wait? Let's just go on with the early approach. Another expert quoted in a news story said, be careful with secondary analysis, but since benefit is better in higher risk patients, the guideline recommendation to prefer early invasive in higher risk patients is reasonable. A third expert, a Scandinavian expert, felt reassured because he said patients with ACS often have to wait a little bit in Scandinavia, and the verdict trial shows no harm in that strategy. I'm drawn to the 5% lower rate of revascularization in the delayed arm. For instance, let's say we incorporated a more widespread delayed, slower strategy in most patients with this condition. That 5% lower rate of intervention would mean a lot less intervention overall. And if you can achieve the same outcome with less intervention, I ask, why is that not the best strategy? The next topic today is how to evaluate patients with chest pain, and I'm going to talk about the Scott Heart trial. On the first day of ESC, Scott Heart investigators updated their original trial results with 5-year outcomes. The Scott Heart trial randomized more than 4,000 patients who presented to outpatient cardiology clinics in Scotland to either a CTA plus standard care or standard care strategy. CTA is basically CT angiography. Now, in their first report, there was a trend towards fewer events in the CTA arm, but it did not reach statistical significance. In this report, this 5-year report, the authors found that the primary endpoint, CV death or MI, was reduced by 41%, or 33 fewer primary endpoint events in the CTA arm. Now, that seems hard to believe, isn't it? That's right. An imaging test reduced outcomes by more than a drug like aspirin or statin. This, my friends, is almost certainly a spurious finding, and what is most notable is that this finding made it to the New England Journal of Medicine with very little cautionary comments either from the authors or from the editorialist. So why isn't this believable? I've written a column giving 5 reasons why I don't believe this finding, but the main one is that the only therapy differences in the two groups was that 5% more patients, a mere 97 more patients in the CTA group received preventive therapy like aspirin and statins. So it is impossible that giving aspirin and statins to just 97 patients for essentially primary prevention purposes produced 33 fewer events. This would mean the drugs had an NNT of 3, and even the most generous take of aspirins or statin doesn't get close to this kind of risk reduction. The next topic today is about fish oil. Last month, a Cochrane review of more than 112,000 people in 79 RCTs found no health benefits of increasing omega-3 intake or taking omega-3 supplements. Now, previous suggestions of benefits from EPA and DHA supplements appear to spring from trials with a higher risk of bias, which was the finding of the Cochrane reviewers. The ASCEND trial here presented at ESC, which I previously mentioned in regards to aspirin use in diabetics, also was a 2x2 factorial design, and they studied omega-3 supplements against placebo, and their results mirror the Cochrane analysis. Absolutely no benefit, even in diabetic patients who are at higher risk of heart disease. The Kaplan-Meier curves of fish oil versus no fish oil are superimposable, even in the one with the truncated y-axis. You know, the Kaplan-Meier curve within the curve that the authors and editors used to accentuate tiny absolute differences. Even this one showed no difference. And so this data confirms my advice to people to eat fish, not fish pills. So that's it for this week in cardiology. I'm grateful that you listened. Thank you. This is John Mandrola from the Heart.org Medscape.
You're listening to This Week in Cardiology from the Heart.org on Medscape.